I appreciate the last speaker talking about summing up a complex problem in 15 minutes, and I will have the same pressure as we tackle the opiate crisis in America in now 10 minutes because I got a 5-minute introduction about how good I'm going to be. So, and I also want to point out the hilarity of the fact that I am going to give a 5-minute talk on substance abuse in Las Vegas. That seems very, very fitting. Just a second, you know, we got great feedback yesterday on the time that Todd and I and Andy got to speak to you folks. I got a couple good comments about my hair. I appreciate that. I feel like I'm losing it, so that really helps my ego to get that positive feedback. But I hate presenting someone else's slides, and these are Michael's slides. I'm sorry he can't be here. So I'm going to talk to the slides a little bit and just kind of give you my 2 cents on what we're doing with Narus Health and this program that we are rolling out. So I'm not presenting this as the solution. I'm presenting this as a think tank type thing that we are doing as an organization. Feeding into this, I want to tee it up because one of the things that people kept asking yesterday is a really great question was, I think I understand what you guys do, and then you showed a video at the end, and then it seemed like you do a whole lot more than I thought you were doing, and does this replace a disease management program or the LCM program that the employer currently has, et cetera, et cetera, et cetera. So I wanted to talk just a brief moment about the way that we really see a patient population. I say patients, a cohort employee population. And I talked a little bit about this yesterday when we go through and identify people. And when we look at people, we hate to classify someone by a disease, but we have to start somewhere. So all of that data analytics stuff that I was talking about that we do as an organization, we screen for the diseases or the characteristics that the employer wants us to screen for. So we do a lot of diabetic management, for example, in people that are enrolled with our program for reasons far beyond diabetes. It's just that when we enroll somebody and we have access to all of the diagnostic codes that that person has, we ask them about them, whether it's gout or high blood pressure or diabetes, and we will intervene in those things. So a lot of people see us as actually replacing a disease management product, I hate that term, or a large case management product with our total patient solution. So I'm happy to talk more about that, and Todd and Andy, can I speak to, I think we're going to be at the booth several times throughout the day. But one of the things that we look at when we're doing data analytics are prescriptions. And let me tell you something. I've written a lot of meds in my clinical career. I have written no greater class of medications than opiates. I think opiates are incredibly powerful, wonderful medications when used appropriately. They improve survival in a lot of situations. People don't realize that. One of the medications that you give someone who's having a heart attack when they come into the ER, one of the first things you give them besides aspirin is morphine, because research shows that it actually improves survival because of the way that these medications work in the body. So this isn't a poo-poo opiates, they're horrible, horrible things, but there's no question we have a significant epidemic that's just taking over our country that has to be addressed in some way. So one of the ways that we've stumbled upon this, how many minutes am I down to now? Oh man. You're gonna give me the extra 5 back? Who am I bumping? Am I bumping? Okay, I'm okay, all right. I like to talk. So one of the things that happened, one of the early cases that we did an analysis for, an early client was a retail agency who really thought that they had a problem in the infectious disease categories. And they were just like, man, we're spending so much money on infectious disease, and a lot of that stuff was an HIV population. And so we did the analysis, like I said, we always do as a company, or we try to do, say, give us the last couple of years of claims history and let us look at your cohort the way that we do as a company. And so we ran this analysis, and then at the conclusion, it was like, yeah, you got a few cases, you're spending a whole lot of money on an infectious disease. And we reviewed those cases and said, guess what? That spend was not misused. Some cases are just going to be expensive, and what you think is a problem because you're measuring it as a dollar was actually legit spend. However, we found something really interesting. When we looked at your cardiac patients, those with heart failure, we found that if a patient who had heart disease was getting 6 or more opiate prescriptions in a defined period of time, their utilization and spend was twofold. And there was really no other variable in the data except the fact that If you looked at how many pain prescriptions they were getting, they reached a threshold where suddenly they were utilizing the health system more. Now, I'll tell you clinically, there's a reason that that could be. It doesn't necessarily reflect abuse. Sean, who runs our data analytics, came in my office about 6 months ago because when we were building some of the rule sets to look at the opiate prescriptions coming through, he was saying, yeah, you know, we got these people in there having 6, 7, 8 prescriptions a month for opiates. And my first question was, well, are they legit scripts or not? Because a lot of people that need pain medications, what do? They go to the ER and then ER doc writes for like 2 days. Right? Here's 5 pain pills and go see your doctor. And they're not going to see their doctor in 2 days. And whatever the problem was, they're going to have it again, and they're going to go to the urgent care or the ER where there's going to be a different doctor working, and that doctor's going to write for 3 days worth of pain meds. So now I got 2 pain scripts from 2 different doctors, which at the surface looks like abuse. But it actually could represent under treatment for an underlying disease. And so I say that because when we look at the opiate use in the population, and we're constantly looking at opiates, the scripts, the prescribers, and everything coming through, I'm wanting to identify a situation. I'm not wanting to speculate what the situation is, because we're going to then as a company investigate, is it misuse or is it under treatment? Because both of those are going to result in overutilization of the health system. Does that make sense? So this is a map of the United States, and this is looking at where opiates are prescribed, and I'm not going to get into the deep details of this, but there's certainly discrepancies in where prescriptions are dispensed relative to the percentage of people in the population. You would expect in denser areas you would have more opiate prescriptions, and there's no doubt about that. We happen to live in a state, Tennessee, go Preds, right? Nashville, thank you. Preds, sorry, thank you. That has a significant opiate problem, and in part that has been a insurance-fed issue. That's a really deep discussion. But the point is, there are definitely discrepancies in geographical regions. And this is one of the things that we look at as Narus Health. We look at this for opiates, we look at this for diseases as well, because if you suddenly come to me with a company based in Mississippi, the first thing I want to do is measure your people against what the population is, because it helps define risk factors for me to proactively outreach to your folks. So if I know that I'm going into an area that has an opiate abuse problem, my staff are going to be much more diligent in looking for the behaviors as they're interacting with people, if that makes sense. The bottom line is, all of you know somebody that's abusing pain meds. You may not know they're abusing pain meds, but I guarantee you know people that are abusing opiate prescriptions. And when I'm referring to opiates, I'm referring obviously to prescribed opiates. Heroin is a common street opiate. There's obviously no pharma data that can track that, but we're talking about prescription meds. And you may not know it, but you probably are connected to somebody who has experienced an overdose, whether it's resulted in a fatality or not. The bottom line is that this stuff is just so incredibly prevalent for a multitude of reasons. And that's just calling that out. I already spoke to the fact that at Narus, one of the things that we do is we monitor prescriptions. And again, this is for any class of medications, but I don't know if you recall the one slide that I showed yesterday had all the little colored dots on it. What Sean does when he does the data analytics and tees up the cases is we look at the frequency of prescriptions, we look at the quantity that a script should have come through, we look at how long that should have lasted, who the prescriber was, and take all of that information, even if we're not enrolled with that person, and reach out to their prescriber. Most states have drug databases. I know in Tennessee, I have a drug database. I have to check it twice a year on patients for blah, 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 but it also lags about 5 weeks, right? And this is stuff people are showing up, and I have no idea who has written things for them before. So one of the things that we're able to do with our data analytics is give the prescribers real-time information on, hey, did you happen to know that so-and-so just wrote for this medication, to potentially alleviate an abuse problem. Oop. This is a nice colorful slide with numbers on it. You can look at those. Bottom line is this costs a lot of money for employers. So how does opiate prescription abuse cause problems for employers? So a couple of ways. If the employee is the abuser, it certainly affects absenteeism and presenteeism in the workplace. There's no question about that. If they have comorbid conditions, it drives up utilization. It certainly causes more claims to be processed, so forth and so on, and it doesn't really create a positive culture. But the funny thing is that one of the things that we've noticed at Narus is we started getting a lot of incoming calls from family members who were employees, who had adult children on their plan still, kids in their early 20s, and these kids were having abuse problems, whether it be pharmaceutical, or someone was talking to me yesterday about methamphetamine or different things like that. We started getting this influx of, I'm really having trouble because I'm in the sandwich generation. I got aging parents and so forth, but now I got a kid that's just really, really having some trouble, and I need to tap into the benefits and the resource to connect my child to treatment. This is how it really started with us as a company, that we recognize there's a significant need in the workspace that no one is really stepping up to fill, and so this is how we said we really need to try to solve for this as a company. These are not wanting to advance. So let me tell you operationally. Let me just look at the, okay, it's 10:30 right now. I got 5 minutes. Let me go long, right? Football, thank you. That was funny, guys, come on. Here's where this is a struggle for us. And there are some relationships we have with employers, and because of the way the contract and the reimbursement is set up, it solves for a lot of this problem, and sometimes it doesn't. If I identify a claimant who has an opiate problem, or it appears they're having some type of potential misuse, or there's something going on, I have a couple of options as Narus. I can call that person, try to enroll them in the service, just like we talked about the other day. I'll tell you, there's a very low percentage of people that will grab onto that, especially if their main problem is they're potentially misusing opiates. A lot of those folks don't realize that they have a problem or need an intervention. I could try to reach out to a beneficiary that's associated with that person, but now why am I calling this person? I mean, if I suddenly call you and say, hey, would you like to enroll in Narus? I know that you don't really have any kind of medical problems, but I'm wondering if you have somebody in your family that's abusing something and you want our support. It's not a really good way to engage people, right? Because we already talked about the skepticism and the cynicism. So we have a challenge as a company that we are needing to try to outreach to the caregivers on behalf of a claimant, respecting the confidentiality of the claimant, and trying to make these folks understand why they would want to enroll in our service. That too can be challenging. I'll tell you where we find the most success with this. If we have a relationship with an employer, especially one where costs are somewhat fixed, and I don't want to speak to cost because that's really Todd's area, but if the costs are somewhat fixed and the employees are highly incentivized to engage with us, and the employer says, you need to reach out to this company because they have an opiate support network to help families that are dealing with this crisis. So it would behoove you to proactively reach out to Narus and ask for their help and support through this experience. That's where we get the most engagement, because there are a lot, and when people know that resource is there. I mean, if I know I'm walking this journey with my son or daughter who is in this situation, and then my employer says there's a benefit, this supportive group out here that may not be able to directly help your child, but they'll sure as heck help you manage through it. And we support you reaching out to them because the costs are somewhat fixed, even if they're not, then the individuals and families are proactively reaching out to us. And this is where we're getting most of our engagement. And the most recent one we had a lady call us, not too long ago, a couple weeks ago or so, who's trying to find rehabilitation services for her daughter who's actually abusing street drugs, but it doesn't matter, drug abuse is drug abuse, who is needing our help in coordinating that care. And we were able to enroll this lady as our patient, if you will. It was the mother that we were enrolling, working the logistics on behalf of the daughter and providing meaningful support along the way. Does that make sense? So this is the way that we are looking at rolling out this program, the way that we're looking at engaging these folks. So far, it's been very positive. The struggle for us is not knowing the high risk, it's figuring out the right way to engage the high risk, right? So these are the things that we're working through. So there's the opiate crisis solved in 12 minutes.